Well, welcome to AI Rounds, where we explore the intersection of AI and healthcare. I'm Dr. Anil Jain, Chief Innovation Officer at Innovaccer, and I'm joined by Jennifer Blumenthal, Product Director at Milliman IntelliScript, Brendan Keeler, Interoperability Lead at HDD Health, and Rick Renard, co-founder of CareOps. Together, we'll be unpacking the latest developments in health AI and their implications for providers, patients, and the industry at large. Now, we have to begin with this topic. There's been a lot of noise around this. Let's start with the EHR wars. As everyone knows, Epic and Oracle are moving quickly to introduce new AI-enabled products to their customers. And about 2 weeks back, at the time of this recording, an Oracle EVP wrote a very strange blog about Epic titled, "Wizards Won't Modernize Healthcare and Wikipedia Pages Don't Edit Themselves," where they accused Epic of running a smear campaign against Seema Verma, the general manager for Oracle Health and also a former head of CMS. Now, Brendan, since you know the space so well, maybe you can get us started. What's going on behind the scenes? What's this all about?
I think the first point is let's not get drawn into the muck. The main point to highlight here is that everybody in the industry, Epic people, Oracle people, the random passerby on the street is like, what are these wild claims? Why aren't you going and doing the thing you should be doing is ship your AI product, ship your interoperability, go build something that you're claiming you're doing. You know, they're trumpeting like a lot of the hype, but go prove it. Go be a QHIN. And so I think most people said, come on now. Like, what is this? And so one layer down, there's a lot of theories about, Ken Gluck. He's got a weird history. Go back and like look at his history with Microsoft and Trashgate and things like that. But, that this was not an appeal to the industry or to the general populace, but an appeal to N of one being the administration. And it's a weird appeal, but hey, stranger things have happened. And so that's where we're at. I think most people have like, they've gone through ViVE, we're going into HIMSS, we're past it. And we hopefully don't see that sort of behavior again, because it's just odd. We don't need it.
Yeah, so for anyone that wants to know a little bit more about this palace intrigue that Brendan just commented on, you should feel free to read that blog. And I know Brendan has actually put some LinkedIn posts around this topic as well that we should, for anyone interested, should go check out. But I love moving past the palace intrigue into the realities of what we're all experiencing. It's not a dull moment in DC these days. We know that HHS saw massive layoffs last week, and at the time of the recording, those are continuing to happen, whether it's the NIH, about 1,500 employees there, 1,300 employees at the CDC, and there are many coming out of CMS and the FDA, including CMMI. Many of them, not all, many of them were working on data and AI-related activities. What do you think about all of this? And, it's, again, not a dull moment out there, but maybe we start with Rick. What do you think about all this? What does it mean?
Yeah, so I was listening to the Plain English podcast earlier today, and they said it best. Like they have it titled like "Fuck around and find out," and I think that's what's going to happen. Like it's very easy to cut costs by firing a bunch of people, and you can go to like Trump and say like, "Look, we are saving all of this money," but it's very hard to predict like what the butterfly effect will be and like the long term win of firing all these people. And so in the weekend, I saw a post by Jan LeCun, which is like an AI wizard at Meta, and he said like, hey, the US seems to like destroying all of our public research funding. So many US scientists are like looking for a plan B. So hey, Europe, if you want to attract all of the best researchers, you can do that now because everyone is like, hell, I want to like get out of this. And so if they go to Europe, good for us because I'm from Belgium. So yay to more smart researchers. If they go to China, that's like pretty bad. And so China is, for example, hiring aggressively on like offering competitive salaries, like making like a lot of investment in funding and like in research, and US is like doing the other stuff, which is very interesting. And what I also don't understand is like cutting 10 billion for example, the National Institute of Health. So that's like 20% of the budget. So like one out of every $5 that universities get is like gone overnight. But if you look at Medicare, for example, it's like 900 billion a year that we spend on it. So like, why aren't we focusing on a program that big and like finding 1% there is already the 10 billion that we need?
Well, I love your comments about the butterfly effect. I think it's a very important concept of the unintended consequences. And perhaps, given the fact that this is all happening to benefit the American taxpayers and the consumers, maybe, Jen, you can comment a little bit about your perspectives. You've done a lot of work in this space around the consumers and what they're expecting from the different agencies, especially around data and AI. Can you give us some thoughts as to what you think about all this?
Yeah, I think that um it I think a lot of the cuts were probably, I know people have been cut. I know people who've had Doge walk into their offices and taking pictures and they're like, I'm not going to have a job tomorrow. So I think a lot of the cuts are really coming down to programs or initiatives that are kind of against the current administration. I would really be interested to see of the actual cuts, what were the titles and roles that were cut? You know, are we talking about the people who, program managers, project managers, people who are maybe running these programs versus maybe people actually working on true AI initiatives, maybe fingers to keyboard? I'd be interested to see overall what it is. I think the biggest concern, obviously, is the public health risks. How does this impact us in case of another large scale pandemic ever happened? But I do think a lot of it is just like the FDA, for instance. I just think they were on the wrong side of the current agenda for this current administration.
Well, that's an interesting thought. I mean, we know that, of course, there are no public health issues going on in the U.S. right now, right? No measles outbreak in Texas, no challenges with communicable diseases coming from overseas. I think your point is a good one, though, which is, who are the folks that are being let go, and perhaps who are being let go and then rehired down the road. Brendan, you must have some thoughts on this. I think we talked earlier in the week about some of this. What are you thinking?
I mean, I think Rick and Jenny said it best. I mean, the human stories of them suck, right? You hear the individual stories of like the CTO of the ASTP and being on maternity leave, and we're still waiting for the full set of shoes to drop, right? You know, the head of the ASTP is not appointed. Will there be cuts into that department? I think is subsequent to that.
Tell us a little bit more about what that is, because that might be a new concept for some people that are listening.
Right, because it's an agency that's existed but is renamed. So last year at the ONC, the Office of National Coordinator and head of the certification program, the main regulator of the provider health IT program, sort of reformulate themselves in the government and into the Assistant Secretary for Technology Policy, ASTP, still ONC like floating on the end over there. And yeah, appointed a bunch of C-suite people that were supposed to be career positions, and then they're all gone. And so they're all cut. I think it's because they're easy because they were new. But I think there's potentially more to come. And so the human stories of all these people is what gets me, just because it's not fair to some of these people. That's it.
Yeah, absolutely. I think that when we have this conversation next month, perhaps we'll look back and say, what was the intended consequence, but also the unintended consequences that we can measure short term. I do worry about the long term consequences that Rick was alluding to earlier. I think, when we think about what the federal government is doing, we're sort of seeing DOGE sort of moving in a very expeditious, break the glass, we'll figure out how to fix things later. But the states are also doing some interesting things around AI legislation. We know that at least 11 states at the time of this conversation are growing concerns. There are growing concerns about how do we regulate sort of the oversight of the use of AI in reviewing health insurance claims. We've had some very high profile stories that we've all heard. And recently, Arizona state lawmakers passed some new legislation that has been aimed to restrict the use of AI in reviewing medical claims. Now, if this was signed into law, the bill would ban AI from being used to deny a medical claim or even denying prior authorization requests before the insurance carrier could actually make any decisions. On one side, I think this seems like a great move because consumers don't want unnecessarily denials from just being out there. But also, on the other hand, and as a clinician myself, some of these rules can be quite complicated, and there is maybe some room for AI. And I think there's a lot of folks who are trying to innovate in this space. So let me just sort of ask you all, what are your thoughts? So you got the federal government on one side, but you've also got the state legislatures trying to pass these rules. Maybe Brendan, we go back to you for a moment here. What do you think about all this?
You'll find I'm generally AI bull is the way I'll preface these things, that I believe in the upside of these technologies. I also find that regulation is best suited when we have an understanding of the abuses, right? The abuses that happen. And so if we see an abuse and we want and have a clear picture of how we might stop that abuse, that's good law, good regulation. I just find that there's a weird dichotomy of, we have on the payer side this regulation saying AI is not good, but then on the provider side we see David Schweikert of Arizona proposing HR 238, which is a bill that says, hey, actually AI can be prescribing, can be acting as a provider when authorized by the FDA. And so that's not passed. I don't think it'll be passed, but it represents a future that is very divergent, very different, where we give providers superpowers, the provider organizations superpowers to augment their staff, but we say to payers, hey, actually, the workload that you're trying to automate, you just can't. You can't even try and do it right. And I think there's room to use AI to improve the terrible back office work of payers. Like, there has to be. Now, does that lead to higher claims denials? Hopefully not. Hopefully it just means that we can turn around claims in 30 seconds and not days or weeks, right? Like, that's the outcome we want. And if we get to this by regulating too soon, too quickly, in the wrong way, we prevent that, then we've done ourselves a disservice.
Yeah. So I think what you're describing in terms of your perspective on regulations, the precision regulation that needs to happen makes a lot of sense to a lot of people who are trying to balance the innovation with patient safety, for example, or patient concerns. But I will also ask, how much of this is really around autonomous AI versus a human in the loop? And there's a balancing act. So maybe Rick, can you help us understand a little bit more? I know you have some background in having virtual care and AI do a little bit of work that traditionally has been done by certified, credentialed folks. So what's your perspective on this?
Yeah, so I'm biased obviously because I'm also a nurse. But first things, like, if you look at the article and like the legislation itself, like what they say is like what they're asking for is that any claims that are denied, that a provider looks at it over completeness. So it's not that they ban AI entirely. It's more like when an AI denies autonomously, then a human needs to review it. So I think that's indeed the invite that the legislation gives, is like, instead of like doing full automation, we need to work towards like a human in the loop model. Like, when things are at high stake, then a human needs to look at it, validates it, and then send it over to like the right bodies and like get the approvals from there. And I think it's like, from a policy perspective, probably like a little bit too fast on the decision. Like, we are already going to ban it, like spend some more time talking with the industry, like understanding, like, are the denials more now than 2 years ago, like stuff like that. But overall, I think like indeed moving towards that human in the loop process makes a lot of sense. Like at SORT, for example, and obviously speaking for myself here, but we also have like a human in the loop process where we have PTs approving the messages that we send, approving like the modifications that we do in the exercises that we send to our patients. And that's working pretty well, because then you have the clinical oversight. And like going from nothing to full automation is like probably a little bit too soon, but going from nothing to like regulating to not use it is also, I think, from my perspective, a little bit too fast.
No, that's very interesting, Rick. Jen, we heard Brendan's position on this and talking about, well, if we're opening up the gates for providers, why not for payers? After all, it's going to be a team sport when it comes to managing patients. And we've heard Rick talk a little bit about sort of the human in the loop aspects of it. From your point of view, what are consumers asking for? What thoughts do you have on having legislation try to put some limits on the way that AI can be used? Any thoughts?
Well, I think you mentioned there's 11 regs right now, but there's 22 states or 11 states that have put regs into place, or they're looking into. There's
Right.
actually 22 states. So if you zoom out, it's not healthcare specific, it's not insurance specific, but there is a larger view at how AI is being used and how it impacts consumers and everything of that sort. So talking to Brendan's point, you have to think about, where is the data created? Brendan knows this, data is created at the point of care when a appointment is scheduled, when the person meets with their doctor, and then that data is that's sent to billing for billing coding, and then that's when it's sent to the claims, and that's where the whole payment, rev cycle management, all of that comes in. So from my perspective, you look at the profits of payers to date, and then you look at our cost of care and you look at our quality of care. I mean, I think right now I would rather see AI used in other scenarios within healthcare. I'm not sure if anybody on this call or anyone listening has ever had this experience, but if you talk to anyone who is very sick or has had a long-standing condition, the fights that they go through with their insurance providers to get their care paid for is so difficult. And a lot of times it does come down to an actual person reviewing it. I don't feel strongly that this is very important to push through to benefit payers at this point in time, but strong opinions loosely held. And as time goes on, I'm willing to change my stance.
Brendan, any comments to that?
No, I want to defer, I know, because I don't want to say something on everything, but I appreciate both of those thoughts.
And I think
Yeah.
from a consumer perspective, we see like a lot of innovation already happening where you have like AI agents automatically like calling to the payer and like navigating the phone tree and then like making that prior auth process also much more efficient. So I also agree like with you, Jen, that like doubling down on like making it better for consumers, it's more important than like making it more helpful for payers for the reasons that you just described.
I think that I want to go back on one thing is I do think that the legislation that helps providers use AI in care settings, the better quality data that we're generating actually is going to help the claims process downstream. So I would like to see better notes, better documentation, everything so that the story of the patient is very clear when it does get to the claims reviewing. Because right now that's still data quality within EHRs is low. It's not that great.
I have a thought.
Well, I think,
Okay, go.
yeah, Brendan.
But it should be like scribes, right?
Yeah, it's connected.
I can just have the conversation and they fill in the SOAP note with all the discrete things like they want to do. They fill it, they code it properly versus Dr. Smith. You need to be like, blah, like, let me put this on the problem list and being like, I'm putting this in the note, because I can't learn this new thing.
Will tell you, I know a doctor who built a homegrown EMR and they used ChatGPT to help them document their notes properly to get things paid for. So like you are seeing hacky types of providers maybe using their homegrown EHRs to kind of do that. So I think that we're going to have to balance regs that are coming out for patient privacy and protection with also innovation. That's the bottom line.
But we also need to make sure that clinicians are not doing things just because they'll get paid for it, but that they're doing things that are in the patient's best interest. And I think, looking at even the work that we're doing here at Innovaccer, I mean, looking at the combination of using ambient to really understand what needs to be done appropriately for the patient, and then trying to lower the barriers. At some point, though, love to get your guys' comments before we move forward on our next topic. When do you see an AI agent talking to another AI agent and adjudicating everything sort of behind the scenes, and as for example, a Waymo car honking at another Waymo car, that sort of model? Any thoughts?
Now, like I see now, like I think that is where, if you're talking about where all of the easy agent workflows are going to be, it's going to be administrative work. The scary stuff, and we'll get to this, I know we'll get this in the agenda, is the clinical side, right?
Yeah.
Providing agents. We're all afraid of agents, but the administrative task, which certainly billing and financial, it falls into that. We're going to see rapid adoption of agents and suddenly, over different modalities. Maybe it's phone, maybe it's fax, maybe it's a digital infrastructure. We'll see AIs facilitating that. I think it's going to be way faster than we can possibly imagine.
I've been working on a project that is like a true interoperability project. It's building APIs from one system to another to transfer data on behalf of, a treatment use case. And I have been thinking about some of the limitations of those APIs in the data that's able to retrieve based out of what's available through those databases. And I have been thinking about, are there potential use cases in my little sector of interoperability Brendan, some of his writings have influenced this, but I haven't now thought about it for a targeted use case of actually that using RPA with AI to pull out the data that we're missing to then send the data for continuity of care use cases. So for my world, yes, I can see that maybe happening. For a larger landscape for people outside of interoperability, TBD, but I think there's a lot of people who know their workflows really well, and then it's those people taking AI agents and applying it to those workflows.
Yeah, that's fascinating. I think one of the comments you made, Jennifer, earlier is that, yes, there may be 11 states that are working on legislation for AI in healthcare, especially around the insurance prior auth and denials, but that there are many, many other states that are working on AI legislation, either from a patient or consumer, rather, privacy point of view, or really thinking through the unintended consequences of using AI in other realms, maybe even protecting people's facial features or protecting their private data. We know recently that the White House, the Trump White House, recently announced a call for public input on the actions that the federal government should take regarding AI. There's a bit of a dichotomy. President Trump has been very vocal and wants to keep the U.S. to be the leader on AI globally. He really, really wants to make sure that we are number one as the U.S. on AI with his new AI action plan. And he's using that to shape the AI policy landscape that will be pushed down to all the various cabinet secretaries. But I also think on the flip side, some of the other aspects of what the administration is doing around the comments we made earlier through DOGE may have a deleterious effect on some of our AI leadership, especially on the research side. And I could be guessing here, but I bet you all of you have been asked as to whether you would be providing comments, or at least have been entertaining whether you'd be providing comments, to the administration through this call for public input. If you were, I'll put you on the spot, if you were to advise the federal government, in this case the White House, Jen, what would you be advising them?
Well, I don't want to get ahead of my skis here, but I guess I feel like the two things that.
Oh, and by the way, none of this is binding. You can say whatever you like.
Okay. So, I mean, my focus for the past, couple of years that I've been working in the healthcare space has been primarily around interoperability. So I think I would kind of lean into that. So it's going to be anything around standardization of data formats and protocols to facilitate exchange for different AI systems and healthcare providers, maybe. And then definitely, this already exists. There are tons of organizations working on data sharing frameworks. So I think, I would hope to see, if I was to submit something, I would probably pull from existing organizations like that and then double down. But yeah, I think it's going to be that. Like, we want to make sure that there's communication across systems and we just don't create all these closed-ended systems that can't communicate. And AI needs that amount of data. And then I assume a lot of the comments are going to be energy related for how do we support this kind of mass need for data and to make AI go to the future. I don't know. That seemed lame the way I said it, but that's what I'm imagining.
So, Jen, what I heard was you are going to push to make sure that we've laid out the right infrastructure in order to make AI successful through data and interoperability, which apparently in healthcare we still seem to be a little bit off on in terms of a national agenda. I also heard you talk about some of the infrastructure requirements in order to power some of the technology required for all the AI processing. Rick, anything you want to add to Jen if you were being asked to put a letter together for comments?
I would be a little bit more high up in positioning it, not as specific as Jen, but so I think first, don't be like Europe and try to regulate every tiny bit of it. I think innovation thrives in environments where risks are managed, not eliminated, and that's what Europe is doing right now. And then I think my specific advice would be how can we promote AI to enter the world of more healthcare abundance? And what I mean by that is right now there's a lot of stuff happening in, for example, fee for service, that when AI is effective there, it will not work because there is for example, time-based requirements on billing. So you had I saw a story, I think it was from an A16Z podcast, where it was someone saying we toggled off our AI agents because they were not, they were too effective. And because of that, we were not meeting our like 20-minute requirement to do something. And so like looking into this like fee for service, like weird edge cases where like AI cannot do its job better than humans because of like the way that the system is created is, I think, like pretty substantial. Because if you look at the data, like we as an industry have like amazing shortages happening, and it will be like only getting worse over time. So all the help that we can get from AI is to like help our clinicians be more effective and like to really bend that cost curve, I think is really important. Because if you look at healthcare today, like 99% of our industry is still very labor intensive. So while buying a television today is like pretty cheap compared to like 50 years ago, getting healthcare today is still very, very expensive. And like if we can get to like more supply by using AI, then we can also bend that cost curve. And so as a government, like really being leading there on like how can we facilitate that world where like the supply is going up because of AI, I think that would be like pretty crazy.
So let me see if I got. Let me paraphrase what you said and see if I got it right. I think what you're saying, Rick, is that the way that our delivery and reimbursement systems have been set up are not compatible with the value that AI brings to clinicians and to the other stakeholders. And the example you gave is a great one, which is if you're going to be billing based on time and AI is supposed to save time, how in the world does that then make sense? And so I think what we heard from Jen was infrastructure, data interoperability, maybe the data centers and the energy requirements for all that, as well as from you, Rick, around just making sure that everything we do in healthcare is actually compatible with the values that AI will bring, especially on the fee-for-service side, which are going to be very different than the capitated patients that we may all see. Brendan, not to put you on the spot, anything you want to disagree with or agree with? Any other thoughts you have?
I think it's important for us to figure out how to pilot AI agents. If we don't say, hey, this is the way we want to try this out in certain settings, the demand side will overwhelm us. That people want to figure this out. They're going to break the rules, and they're going to cause a lot of fear, uncertainty, doubt. And we're going to have fraud, waste, and abuse, and all these problems. So, going back to Rick's Europe example, wow, drones are way ahead of us in Europe. And why is that? It's actually because it's regulated. They said, actually, here's the way you do it. Here's the way you can do this really cool advanced technology and get your cup of coffee in 2 minutes in a suburb, right? Like where Uber would take 15 and be cold. And so Europe does lag and overregulates. No, sorry, Rick, but you know this, like the bottle cap thing. But regulation leaning into innovation to give the right setting where there's a no right now and turn it into like, oh yeah, go try it in behavioral health for this in this way because there's such a shortage, really smart regulation. Then we say, holy shit, it's outperforming. It's curing this big shortage, right? And then we can say, okay, how do we do this elsewhere? And so building the sort of pilot space rather than saying, how do we block it? How do we stop it when it is inevitable that all roles will be changed by this? My role, consultants, everyone's saying McKinsey and consultants are done. Not wrong. If you tried deep research. And so we can be afraid of it. We're going to say, how do we level up and change into the next set of roles? How do we find who we're going to be, just like with the Industrial Revolution? And I think the government leading into that and saying, here's the pilot program. I have a ton to say on the infrastructure side too, but I'm going to just keep it to this one comment. That's my way of making us all get over our fear, uncertainty, and doubt of.
So your recommendation, if I got you right, your advice would be to create some waivers so that people can do some pilots to really discover what's working and what's not working, so that before we start putting policy in place, we're actually using data to drive that thought process, and not necessarily to be afraid of regulation, but to make sure it's more precise so that it actually helps accelerate innovation instead of stifling it. Is that fair?
Yeah, things that are banned allow in certain areas. Waymo in San Francisco, and everyone's like, shit, that's awesome, right? Like anyone who's tried it's like, oh wow, that's pretty cool. And so those sorts of things where we say, all right, we're afraid of this agent thing, let's try it. And if it's abject failure, we've contained it, and we can say, maybe not now, or maybe not ever. But then we're leaning in and saying, let's go be leading in this so that we can get to the 10x efficiency. Because scribes are the scribes are a 10x efficiency for the user. Agents are 100x efficiency, 100x value for the organizations. They're going to fundamentally change how organizations are run.
Yeah, and I'd love to see agents take off, and perhaps they'll be taking an exam like the kind I had to take before I could practice medicine and prove that I knew certain things. But the exam doesn't make a great doctor, right? There's other things, and so as we think about agents in the clinical space versus agents in the back office, front office, mid office, it'll be interesting to see what requirements will states or even the federal government impose on these agents before they can start doing things that humans had to do. I know, Rick, you in your firm will be looking at that very carefully to see what can and cannot be done. I do want to move on to another topic. We had come out of the ViVE conference that happened a few weeks ago at the time of this recording, and there were a few large AI announcements that were made. We heard that Cleveland Clinic had picked Ambience as their scribing vendor. We also heard that Abridge had announced a $250 million round led by tech investor Elad Gil. And Abridge was also an early participant in the Epic Workshop program, which is Epic's co-development partnership program. At least that's the way it's been described. But Brendan, can you sort of describe how it works? How open is Epic really? And what does this all mean when it comes to really thinking through their workshop program? How should all of us as AI innovators be thinking about it?
It's very easy to be like, wait, man, this is a shit program. And I wrote a piece that like highlights all the deficiencies of their current program, but I'm going to trace how they got here really quick.
Yes, please. I think the audience would appreciate that.
They released the App Orchard, and the App Orchard was you apply to get in, and it was sort of like you work through this long process, and the backlog was huge because everyone's trying to get in, and then you have access to see all the APIs and all the connection points, and some new app developer, don't understand an outpatient EHR, let alone the complexity, the beast that is all the different modules of Epic, right? And so you're looking and you're like, what is a smart data element? What's all this? And you're overwhelming their TS support, which leads to a further backlog of App Orchard people, which they can't process and get through. And so they say, this is not working, and people are mad at us, and people think we're blocking to allow people in, which they probably were in some capacities. Who knows? Like, they're not a homogenous beast. They are people within an organization. And so some people might selfishly block for their app and some might allow in. I don't know. But by and large, they said this is not a feasible program. And the Cures Act meant that it's not feasible, that you have to charge in a different way, that you could not charge on revenue, that you had to charge on usage, that you could not differentiate your services entirely in the way that they were doing. So they said, we have to revamp this. And they revamped it to be, vendor services. So vendor services is the developer program. You can join. Anyone can get in. Super cheap. You get in. You get access to documentation. You can't see all the APIs, but you can apply with your workflow, and then they triage it and give. If you need something that's private, they point you to it, and they give you access to the private API. And if you don't, then they say, here are the standards you should use to actually do your workflow. And if you think they're wrong, luckily you have information blocking to smack them with, because it's entirely in your favor. They cannot prevent access to an API that they have available. And so they're cognizant of that. That's the developer program. You should be in vendor services if you're making an application. There's no reason not to. Then there's Showroom. Showroom is their marketplace, and there's 3 tiers. Connection Hub. Are you live with one site? You cannot pay them for that status. You need to be live with one Epic site. That's it. That's all you need to do. You don't need to be in vendor services, actually. You can do it just like through old HL7. And then you say, hey, Epic, I'm live. Boom. Toolbox. You are a defined category that they already recognize. They say, this is a workflow we know. You are a bedside monitor. You are an identity verification solution like Clear. Here's our blueprint. If you follow this blueprint, this is the way you do it. And you get access to APIs in a special status. Yeehaw, like amazing. Not always amazing. It's not always the workflow that you want, but the way you want it. So you don't have to do it, but it's there. Lastly, Workshop. This is where Epic says, this is an emergent technology, and I have no freaking clue how to do this. And I need a partner to co-develop it. I need a market-established leader that already has a dozen of my customers to figure this out with me. They choose you for Workshop because they are working, and they say, we want to be leading in this, and this is an edge, a hard edge with hardware or ambient or something that we are not capable or willing to do, and we need to figure it out with somebody. That does not mean that it precludes anybody else doing that from getting access to the APIs. Quite the opposite. They've been very clear that once developed, those APIs are available to similar people in the similar category. But it is a huge leading edge. And so you see things like a bridge gain a lot of ground as the AI scribe category. If you'd like to learn more, I wrote a long blog post about this, but that's the short version.
So, Rick, Jen, any thoughts? Any experience that you want to share that do you think Brendan's got it right?
Yeah, he does have it right. I remember when we applied for App Orchard, I just submitted the app. Like this was like 2016, 2017. I was like, I don't know if we're ever gonna get in. And then I remember one day we got in. I was like, oh my God. And it was great because I paid for that subscription just to get help from support, right? And I hacked the system a little bit. I would literally use App Orchard support in order to get help with just the open APIs. And then now I kind of go through different channels. We have, within vendor services, we're building applications that are not direct to consumer anymore, but more for B2B purposes. So we're leveraging that ecosystem. We still use the open developer stuff, but like overall, like in the new tiers that Brendan just talked about that rolled out, there's a benefit to that because you want to be acknowledged for, yes, you have a solution in the market that works and has been used by other Epic sites because Epic sites will look to that if they're configuring you on the back end for utilization. I have a great experience with Epic. I can't complain. So keep going.
So Rick, what we've heard is that there is no friction for AI innovators to work with Epic. Is that?
Well, there's friction, but you
Oh,
work
there's
your
friction.
way through
There-
it.
You wave through. Okay. Well, what I heard from you, Jen, was that there are workarounds. is what
You learn how to work with Epic to get the answers that you need. That is my advice to all developers within the ecosystem.
I just want to be like do my like hottest short take here, and Rick, then you can go. Developers are babies in healthcare that they cannot try and figure out the process that they feel that they default to. I'm being blocked rather
Yeah.
than like, read the docs, talk to somebody. I'm available. I'll talk you through it. I'll help you through it. I'll help you maximize your integration. Do a little sales pitch. But like you can achieve whatever you want with any EHR you want, and you just have to be willing to do it. And there's this false narrative that there's every other industry has the same APIs and it's super easy across all the B2B SaaS in the world. That is bullshit. If you look at property management systems, if you look at any other B2B SaaS in the world, they have terrible APIs. They have blocking on every front from you to come and try and build point solutions next to them. And so to act like B2B SaaS is different in healthcare with EHRs, you probably haven't worked in many industries if you think that realistically.
Yeah, and I think a lot of new developers, they like some of the best holy grails are old chat rooms. Like people just ask the same question over and over again. It's like, hello, people, read the room, literally read the chat. You can find the answers you're looking for.
Well,
Sorry.
I think I'm probably one of those people who think that in healthcare we haven't gone as far as we have in other industries to set standards when it comes to both the noun and the verb. Oftentimes in healthcare we're put in the positions where our patients who might be seen across the street, we don't have ready access in a meaningful way to their information. But I get your broader point, Brendan and Jen. Rick, any thoughts? I mean, it sounds like we have solved healthcare interoperability from an API level, and that we ought to be focusing on training up the developers to just Google it, or to go on to to appropriate, or to reach out to the appropriate experts who know how to do all this. I
think that's it. Like, I don't know if it's an English word, but in Belgium we say engineers are luxury kittens, in the sense of like what Brendan said. Like they are used to like having very good API documentation. Like you can set up an integration with Stripe in like 5 minutes, but healthcare is a little bit more complex. But like one, like suck it up and deal with it, and then second, go in your cave and like read Brendan's Substack for like whatever time that you need, and then you will figure out a way. And I think we should be very grateful for like all the content that we have today, because like 5 years ago when you needed to integrate with Epic, it was like much more like complex and what the fuck. And now you can like go to creators and like read some content and like just figure it out. So yeah, I think we indeed solved interoperability just now.
I would add, so I can see after all the years of working on this, the questions that I've asked EHRs and then their developer ecosystem makes it back into their dev docs, right? And the best thing you can do is also if developers are integrating across EHRs, because you're going to start seeing patterns of implementation and or deviations or variations of any sort on how they interpreted specs, how they put it into place, and then you start to learn how to essentially integrate across systems. And that's more of point-to-point integrations, but overall, I mean, it is way easier to be a developer today, 2025, than it was 2015, hands down. So let's see what it looks like in 2035.
So we still have a little bit of work to do, is what I'm hearing.
The work is never ending. I think
Okay.
the false narrative, the human condition is to push beyond and to look back and say, wow, that was so shitty. Let's do better. E-prescribing is ubiquitous, but we have Photon Health saying, wait a minute, couldn't the patient transfer should we be able to transfer my prescription? There's always more work to do because we have not fully digitized everything that's a phone call or a fax. And that's not just in healthcare. When I'm at, if I'm at, a life insurance company, they'll sometimes call or have to look things up or have to fax something. We have not digitized every workflow between every organization in any industry. And so as soon as we do, we're going to look back and say, wow, how rigid, how we did all these standards and now we have AI and we can be super flexible. Let's build the next amazing thing. But there's no solving it because we're going to look back as soon as we do and say, we built the trains and now we have cars, let's build the highways.
Yeah, and I think for AI, like especially as you start implementing it more and more workflows, like this is going to be the same undercurrent, right? Talking about its progression and how we're utilizing it in those workflows, and it's going to be the same complaints because developers tend to complain. I liked that. What'd you call it? Luxury kittens? That's great.
But we have none of those at our organization. But I think what I'm hearing, and again, maybe this is a topic for another conversation, is that yes, interoperability has come a long way. Yes, we can empower developers with the right material to be successful in what they do. Yes, we still have some work to do. But your advice to the federal government in the AI, sort of call for comments would be do some more on the data and AI on the API side. Keep pushing it because the new use cases will keep pushing us in different directions. I think that makes a lot of sense. And a lot of that might be coming from patients, is what I suspect, that patients are going to want more and more to be done. We saw a recent article, and maybe Jen, I'll ask you to comment on this first. You probably have seen the article that was in the New York Times that AI chatbots are now providing therapy. As a physician, I do worry about a little bit about chatbots providing therapy, but potentially that's happening with or without oversight from licensed professionals. What do you think about the AI therapist category and whether we should be making AI therapists widely accessible to consumers? Any thoughts? You've done a lot of work with consumers.
Yeah, well, consumers are chatty. I used to get a lot of very chatty users through our help channel. And, I generally think, so when I think about therapy, I think they're obviously the behavioral health category is sensitive, but there are some benefits right now. So, 24/7 care, right? The ability to talk all the time when a provider might be off hours. I like the concept of I think providers and how they implement it, it could be useful. So intake, sending out questionnaires, getting that information back. I like the idea of the 24/7 care if it's off hours and then being able to review that. We do have there's a lot of very sad, lonely people, high anxiety out there. And I think the ability to just have something to communicate with is going to be beneficial. It could bring costs down to receive care. But then I think there's a line, and I'm not a provider. I did not go to medical school like yourself, but like, where is the human element in this? I do think you can't just replace humans who can really see more, hear more than an algorithm at this point. But there are places it could be utilized in the workflow. So bottom line, I'm for it. The brain is one of the parts of the human that is the least understood. It's very complicated, and there's still a lot of secrets that we don't know. So I'm interested to see where this goes. Prescribing is a different thing. I'm I'm not sure that algorithms should be prescribing medications at this point in time.
What if it's Lipitor for cholesterol lowering? Lipitor is typically safer than Tylenol, which we can get over the counter. Are there maybe some use cases where prescribing might be okay? Or do you see that as a line that we don't want to cross right now as a society?
I think there's a line right now because like I'm thinking of I'm thinking of what constitutes a provider, their access to data, things of that sort. I think right now it should really be focused on helping people. Yeah, I'm not ready for prescribing yet.
But
Okay.
but
Well,
it's
go
there.
ahead, Brent.
But it's there, right? Sorry to interrupt, but like we've seen cerebral, we've seen the accusations against Particle's customers. The erosion of the protected powers is the impact of the internet, right? What took a in-person visit and a movement of the script, the friction of manual in-person behaviors, that was a preventative barrier against widespread abuse. Abuse happened, Dr. Jain could prescribe me something that I'm not like the ADHD meds I don't need, but I just want for fun. Totally. But then it's contained to a geographic region with a lot of friction. The internet removes friction. And so now, how do we maintain the frictions that are necessary to prevent abuses is the great challenge of digitization of the internet. And AI only makes it harder because now that AI could outperform a provider or could for any job, not just providers, but for at some point, as compute continues, as the massive rise of AI and the power of DeepSeek and Grok 3 and all these compound, eventually they'll be better at everyone at most tasks, and that
But I think
includes clinical guidelines that that they can make the right decision. But can we trust that the AI behind the wall, behind the system that we're talking to, is one that is doing good and following the rules, or is it one that is just totally following a different set of prerogatives, one of greed? And that occurs today, and it's only made accelerated by AI because there are going to be, before it's like, well, they can't be as good, but now potentially they could, and we as a society have to figure out, holy shit, do we let them pull clinical data? Do we let them prescribe? Can they pull eligibility? Can they have all these superpowers? Because essentially we're delegating it to the consumer, the patient, with the thinnest of barriers between abuse.
So
I do think, and I'd love to get Jen's comment on this, perspective on this, but I do think we need to differentiate where we are using autonomous AI to prescribe versus using AI with a human in the loop. Because I think the augmentation, no doubt about it, there are things that AI does really well. Think about it in radiology and in dermatology and any of these imaging fields. But I just want to make sure that folks understand that AI, at least as far as I know, today in the US, there is no prescribing happening with autonomous AI, given the licensing requirements that one must have. Jen, you had a comment. I'm sorry.
yeah, I was gonna say, look, pill mills exist today. A patient could get on a telemedicine visit and get prescribed what they want. But
Right.
like when I'm thinking about AI used for therapy, I like it to, analyze that data, identify patterns, and help the provider make decisions. I would prefer to see pharmacists look closer to what pharmacists are in Europe. Like that's the route I would go personally, than giving them prescribing power, giving AI therapists prescribing power right now. Like I still want humans to be part of the care continuum.
So you'd prefer this human is the cerebral human is stamping the just everything that comes in on the website. Like pill mills exist, and so like what is the difference between Dr. Smith, who's just clicking yep for the ADHD meds or the ketamine or whatever it is that you can just order online now?
Well, the difference is I can revoke Dr. Smith's license
Yeah.
when he makes a mistake or she makes a mistake.
Who holds AI responsible right now? Like that's a lot of the regs, right? Like it doesn't have an MPI, it doesn't have a medical license. Is it an extension of the provider's medical license the service that they've offered onto the market? Like I have a lot of questions around that. I would prefer to see pharmacists to be able to prescribe the medication I need and so lower the cost of care. That's how I see it right now.
Well, Rick, you probably experience European pharmacies, given your background. Brendan and Jen have made some comments. What do you think?
So my overall fear is that if we indeed have AI prescribing medication, won't we then see more pill mills than we see today? Like that's my fear. Like because right now you have indeed pill mills about like very specific medication, but if you expand the responsibilities that AI systems can have, like everything can then be a pill mill. So that would be like my fear as well. And so I think that then comes back to indeed regulation and like where do we allow AI to act autonomously and where do we don't allow autonomous decisions? And then indeed it's like licensing and all of those questions, like who is responsible? Is it like the care organization using the AI technology or is it like the vendor? Like I have many questions. So I don't think prescribing specifically will happen anytime soon. But yeah, happy to disagree on this.
But I think Brendan's making a really good point, which is it's in effect happening because of shortcuts that providers are making. Maybe they're over trusting the AI algorithms and just rubber stamping it. But I do think that the liability issue is one in healthcare that is going to help figure out what is the right pace at which we move forward on this. There will be a day where AI will provide therapy for certain conditions at the same level that a human being will, or be able to evaluate someone for a prescription for a low risk medication at the same level that a traditional primary care doctor will. I think Jen's comment about the role of the pharmacist is very intriguing because then maybe you have an additional touch point that could serve that. Well, what do you all think in terms of, is this a 5-year horizon, a 10-year horizon? Is it going to be part of your comments to the administration about how we might accelerate this or slow it down? What are your thoughts?
I think we should figure it out. I think we should lean into it and figure it out rather than being afraid of it. Because otherwise we're sticking our heads into the sand that it's happening already. I think we're saying, like there might be a little bit of abuse, rampant abuse of these nationwide networks to pull clinical data, rampant abuse of e-prescribing today, rampant abuse of eligibility checks. And if you pretend like it's not happening, then we're not gonna be able to fix it. And the only way to fix it is to say, we're going to do this in 3 years. We're going to figure out how AI can supplement our shortages and do these things, and then have reporting, have visibility, have transparency to prove that these are not just, Gordon Gekko, geared towards greed in this era of greed is good again, which it certainly is a risk under where we are today in this decade. But leaning into AI and saying, we're going to do this, we're going to figure out the guardrails is the way to build a paved path. And then when people abuse it, say, you're wrong. And if you don't build the paved path, and we stick our heads in the sand, then it only gets worse because the demand continues to go up.
Jen, you were about to... Oh, sorry, Rick, please.
I just wanted to make like the point of like prescribing is not the same as like the original topic of like AI therapists. I'm like very bullish on like having this because this solves like the human bottleneck. When I wanted to have therapy, like I needed to wait 6 months. The session cost like $80. So to Jen's point, like if you have like therapists and then we have AI that augments the therapy, like how powerful could that be? Like I'm talking to my chatbot about like the little stuff and I can go to my therapist and I talk about the big stuff that bothers me. And then I come back home again. And then the AI chatbot gives me like the right workshop or like ideas on like how to use specific CBT techniques. So I think like from that perspective, like yes, doubling down, and then on the prescribing perspective, like go a little bit slower, but indeed like don't ignore it because it's indeed happening. So I think Brendan raised some very good points on that.
Yeah, but Brendan said 3 years. Do you agree with the 3 years, or do you think it's going to take us longer?
In Europe, maybe 10 years, and in the US, probably 5 years.
Okay.
You
Jen?
believe the next admin is Trump 3? Because if so, maybe like next admin.
I think therapy is the perfect rollout if I was in control. I think therapy changed during the pandemic because people had to change to Zoom, right? So I can see augmenting it would be so interesting to see a therapist who already is conducting most of their sessions over Zoom, starting to build prompts with a chatbot so that it's kind of mimicking them and how they conduct their practice, and then using that for 24/7 care. And then, as I said earlier, analyzing the data and kind of building an infrastructure around that. So I think the goal shouldn't be, the end goal is the chatbot is used for prescribing, but the chatbot is really used to really provide care at all times, because I think a big problem with therapy is the cost, it's the access, and Zoom kind of fixed the access part, but now it's really helping people faster. I mean, think about how much time you can decrease. You always hear about people saying, I was in therapy for 10 years, 20 years, and then I had my light bulb moment. Like, can we get to the light bulb faster?
No, that's a great point, Jen. I do know that there are, we, as clinicians, we have to keep up on the literature. There are many examples of successful AI chatbots helping patients with certain types of things, smoking cessation, for example, helping them support them on mild depression. I think, not to be the skeptic, I think AI therapy, AI-based, AI chatbot-based therapy probably is the right place to start. And maybe you start with low-risk ones. But there's an inflection of recognizing when someone does need a human in the loop. And I think that's an area where we should be piloting and innovating very quickly, because whether it's 3 years or 5 years, we don't have enough therapists. We don't have enough primary care doctors. We don't have enough professionals to manage the chronic disease crisis or the mental health crisis that's going on, whether it's in the U.S. or overseas. So I completely agree with the comments about us getting started. I do think, though, at some point, someone's going to ask, does an AI chatbot or an AI wizard need to have a DEA license? Does it need to have a medical license? Does it need to pass the same exams that human beings do? And it'll be an interesting time when we start to ask those questions. Just like a self-driving car needs to pass a driver's test.
And I think between now and answering those questions, like the most important part is like just building whatever like AI technology that will touch patients, like building it with clinicians at its core and like asking their like input and like continuously involving clinicians and putting clinicians in leadership positions. I think that is the most important part right now.
Absolutely. Nurses and doctors. And the consumers. They need to have a voice in this as well.
Yeah, I think consumers will adopt this technology rather quickly. They're already kind of using AI in different sectors in not in the way that maybe the developer expected them to. So I think this would take off.
Brendan, any last thoughts before we wrap up? Our hour has gone by very, very quickly here.
No, just reiterating what I said before. I think the right way to approach it, to overcome the fear, uncertainty, and doubt is to say, oh, I'm afraid of e-prescribing. All right, let's create the pilot, the conditions for a very small situation to say, what does it look like? Was it a success? Was it a failure? And then, because the upside of agents is 100x co-pilots and human.
Yeah.
And so if we can get there quicker, then we win and other places don't. So why not try that and have better healthcare sooner?
So more precise regulation, pilots and learn from them, move quickly, but learn from them. Make sure we incorporate clinical leadership into how we design these pilots, and make sure we have the voice of the consumer. Is that fair? Awesome. Well, thank you all. I think this was a great conversation. I look forward to our next AI rounds. Thank you again, and I'll see you all later.